Okay. Okay, everyone. Let me introduce to you Dr. Shereen Hafez, Professor of Conservative Dentistry, Faculty of Dentistry, Cairo University. Lecture title, Therapeutic Bioactive Regeneration Approach for Pulp Protection. Okay, you can start.
Good afternoon, everyone. Thank you for the nice presentation, my dear Professor, Dr. Ali. I'm greatly honored to be among you today in the first conference of October 6 University in coordination with the Egyptian Dental Syndicate, the EDIC. It's a great honor to present in front of my dear professors and my dear colleague. This presentation will be quite different. Allow me to introduce myself first. I'm Dr. Shereen Hafez Ibrahim. I'm Professor of Conservative Dentistry at Cairo University. I have several aspects. I'm clinician, academia, and overall, I'm a researcher. So today, the presentation will combine the different aspects, the academia with the clinical practice, and what does the research say. Our topic today is termed or is entitled the Therapeutic Bioactive Regeneration or Regenerative Approach for Pulp Protection. The title might be quite difficult or unclear for someone, so just remember it is the TBR approach, Therapeutic Bioactive Regenerative Approach. Let's start our journey. This presentation is based on true story. Story that is encountered daily in our dental clinic. The enemy in this story is dental caries, and the victim in this story is our patient, and fortunately, the hero of this story is you. Everyone present here in this hall today, everyone caring about his patients and want to give his patient the best treatment ever. So, the story began with initial caries in the patient mouth. These caries will be neglected from the patient as there is no pain. So he only visits his dentist when he feels true pain, and this time you should know that the pulp is screaming, is asking for help. So this is the beginning of the death cycle of the tooth. Upon exposure or approximation of the caries to the tooth structure, the pulp began inflamed, and the tooth screamed, I need real help. So the patient comes to your clinic and say, doctor, I cannot sleep, I cannot eat, I cannot do everything, so I need a treatment. However, the only chance we have now is to remove the vitality of this pulp, to remove the pulp, and to replace this pulpal tissue with endodontic treatments, artificial materials, followed by intracoronal restoration to support the tooth to perform better in the oral cavity, and extracoronal restoration. However, in some cases, all these treatment procedures will fail, and we lost the tooth. So, our mission today is to save the tooth and not to extract our precious tooth. Pulp exposure, this is the cases we are talking about. When you excavate the deep caries, we face now with exposure site. The exposure site might be clear and obvious, or sometimes it might be unclear, such like the presence of thin, very thin, delicate dentine bridge over the pulp. In both scenarios, whether it is macroscopic or microscopic pulp exposure, we have only two pathways. Either to go for direct pulp capping or for indirect pulp capping. This is that simple? Yes, it is that simple. But the secret is, you should know first, what is lost? What is lost now? We lost the dentine. The dentine is a very meticulous and delicate structure. The main component of dentine is collagen. And the collagen, we have two types of the collagen. Type 1 collagen that is responsible for the stabilization of the architecture of this dentine, and type 3 collagen responsible for the elasticity of this tissue. Also, we have extracellular matrix. This matrix is very important for the nutrients and the vitality of the tissue. Also, we have the non-collagenous protein, such as proteoglycans, phospholipids, and enzymes that is responsible for the dentinogenesis. Thus, this vital tissue have a self-regenerative power that is noticed through our time by secondary dentine formation and also by reparative and sclerotic dentines that is formed through time. So, upon exposure at this site, what happened? The door is now open for invasion of the microorganisms, so the body has to defend itself. It releases inflammatory mediators to face this invasion, and here there is great inflammation of the pulp, and the pulp is now need a therapy. So we are going to place a pulp capping material as a therapeutic treatment for the inflamed pulp. Is that enough? Is that enough to place just the capping material over the exposure site? The gold standard, or the benchmark we regularly use in our dental clinic is the calcium hydroxide, right? Do you know that the success rate of calcium hydroxide is highly fluctuating? It differs from 13% to 97% success. So that means that we place calcium hydroxide and stay praying, God, please heal. Please, my dear pulp, heal. I need reparative dentine right now. And this is nonsense. In science, this is nonsense. How to depend or rely on a material that have 13% success rate? So the science began to think in different way. I need a biomimetic material. I need a material that could stimulate good dentine formation. And thus, this material will protect the heart of the tooth, the pulp own heartbeats. The biomimetic materials available in the market nowadays are Theracal, Biodentine, and Bioaggregates, right? All these materials have the capability of simulation of regenerative dentine formation. Which material we will choose? And why these materials are reliable? Because science said that the success rate of these materials are ranging from 80 to 100%. This is a real and great success rate. Now we can rely on this material opposite to calcium hydroxide. But the question arises, why this material having this great success rate? Let's go deeper in biology and understanding of the concepts. Histology or biology said that upon placement of the calcium hydroxide over an exposure site, it could not form dentine bridge. At the first 15 days, which is the most critical time for pulp to heal, opposite to materials such as MTA, biomimetic materials, it could form a very thin dentine bridge, as you could see here, in the first 15 days. So that's the reason why the success rate here is much more stable, opposite to calcium hydroxide. However, after 45 days, yes, dentine is formed with calcium hydroxide, but the formed dentine is not homogeneous. It's fields of voids. However, with the mineral trioxide aggregate, after 45 days, you can see a thick, well homogeneous dentine bridge is now formed. And this is explain why the success rate for these biomimetic materials are more interpreted, or could be interpreted, and are more than calcium hydroxide. Okay, which material will choose now? Theracal, MTA, or biodentine? Let's understand the material when are using this material. We are going to play with the material, right? So we have to understand what you are playing with. The Theracal, actually, I do not recommend any resinous material in close approximation to the pulp. Okay? It's resin. It will induce more inflammation for this pulp, which is already inflamed. So if there is a microscopic pulp exposure, I mean a thin dentine bridge still existing, you can use safely the Theracal. However, if you have clear pulp exposure or a macroscopic pulp exposure, I advise you to use the biodentine and MTA. The Theracal, as I said, it contains a resinous phase, and thus the cytotoxicity of this material is very high. So instead of obtaining regenerative power, we will obtain what? A damaging power. Okay. However, regarding the MTA and the biodentine, both are not containing any resinous phase, so it is recommended to be used over direct pulp exposure. Both materials are cytotoxically safe. And MTA induce dentinogenesis formation, induce dentine regeneration. However, it might be difficult in manipulation, has long setting time, and the arsenic content present in this material may cause a kind of inflammation or toxic effect over the patient. So, biodentine much more safer than the MTA, although they have the same composition, but it is easier in manipulation because it is in capsule with short setting time and do not contain or doesn't contain the arsenic phase, so it is much more cytotoxic safe. Okay. And now what? I'm a researcher. What does literature do? I browse on internet and found that we have 153 research on both material, whether MTA and biodentine. This is on the PubMed. Great research, and all research confirm what I'm explaining to you now. And also on Cochrane Library, another search engine, I found that we have more than 580 trials, clinical trials, on both material, and 4 systematic review, which is the high level of evidence, and all these studies agreeing with what I'm saying. So, this systematic review, the latest one, on 2022, carried on 14 articles, stated, please avoid any resinous material in close proximity to the pulp, and that the MTA and biodentine are great for pulp capping. Returning to our topic. So, what is the recipe of the TBR approach? The TBR approach it's a combination of several materials. I need what? I need a bioactive molecule to perform proper adhesion so I do not suffer from any leakage or any invasion of the microorganism again. I need some nanoparticles interactive to provide the maximum bioactivity and antioxidant and induce healing. I need some growth factor to simulate the regenerative power of the pulp. And also I need a therapy to reduce the inflammation. So here come the abbreviation: therapeutic, bioactive, and regenerative approach. So our TBR approach, it was stated in this article, is this the future of dentistry. However, I said now, this is not the future, this is the present of dentistry, and the future is carrying more. So, when the TBR approach started, The start was in 2011 when a researcher found that I need to heal the proximity of this hole. I have now a hole, exposure site, right? So I need to guide the tissue to regenerate in this direction, to meet together to form the bridge. So he used a scaffold to bridge the gap. This scaffold used in this study was hyaluronic sponge or a collagen sponge. The result was amazing. Now we have guided regeneration. They direct the pulp to heal and form the dentine in these directions, direction of the scaffold. That was great result. Then in 2012, Sir Jordan from UK and Professor Dr. Yamanaka from Japan obtained the Nobel Prize in what? They found that the pluripotent, the mature stem cells could be differentiated into a pluripotent cell. It seems the topic is quite heavy on someone, but let me simplify this statement. They discovered that our mature stem cells could be differentiated to a baby stem cells, undifferentiated, that could differentiate into any other type of tissue I want. I want to differentiate it to develop a heart, to develop cartilage, to develop a bone. This is a pluripotent stem cells, a baby stem cells. So, at this time, the TBR approach invade the world and change all concepts. Now, I could regenerate dentine. I could heal the tissue, the wounded tissue. And at 2018, this systematic review or this review start to discuss the ability of tooth repair and regeneration. Then let's understand where comes the healing power of the pulp, how it has self-regenerative power. This pulp tissue is very rich tissue. It contains stem cells, the vascularization, the growth factors. Everything is present here, inside the heart of these tooth, inside our pulp. So, let's talk about the stem cells. This article was published in 2018. I was a researcher with others and my colleagues, and we found that we extirpate the pulp from dental tissues, from extracted tooth, and discovered under the microscope without placing anything over the pulp, okay, except for some antibiotics and some material as disinfectant. And we discovered that after 7 days, this tissue began to form a dentinoid-like, you know, these dark spots, it's dentine-like tissues. It began to differentiate all by themselves. So, another study may answer some question rising in our head now. What about if the patient is aged? The pulp condition is not that good, it's inflamed. Could these stem cells to regenerate with the same power as an adult or young pulp? Yes, it could be, by some help. The help here is the gold nanoparticle. We could use some gold nanoparticles to reinforce and reactivate the stem cells to form reparative dentine. This is very interesting studies carried in our department at Cairo University in 2019. They use capping with calcium hydroxide versus capping with stem cells. Could you imagine something like that? I bring the stem cells and placing over the exposed pulp. Here, there is a critical issue. First of all, this study was carried on animal. It could not be, for ethical reason, carried on human, because it is not approved yet. Secondly, could we use cell regeneration? Is it safe? No, it is not safe, because, as I said before, the cell could differentiate to any type of tissues. It could be even differentiate to a malignant tissue. Okay, so I cannot control the cellular differentiation using the stem cells. So this is uncontrolled process. But the interesting in this article that it reveals that as seen here in these figures, that the calcium, that the stem cells alone could cap the pulp as efficiently and more efficiently than the use of the calcium hydroxide in these cases. Okay. I need in previous study, I say in previous studies that I need a scaffold, right? So what is the scaffold? The scaffold is, I said, is a bridge that will carry these stem cells and these materials that I need for regeneration of the pulp and gives the nutrition to these materials and this tissue. So it helps in regeneration. Which type of scaffold I can use? The scaffold could be natural, and I do prefer natural scaffold, such as collagen, normal collagen, or glycosaminoglycans for biocompatibility. And it could be artificial. This is the PRP, is another natural scaffold. You know what is the PRP? Do you hear about the treatment with plasma? This is the plasma treatment. We just aspirate the blood, centrifuge the pulp, and obtain the plasma and use it as a scaffold. And also we have another natural scaffold which is very promising, the PRF. The PRF is second generation of the platelet PRP, is the second generation of the platelet-rich plasma, and is very efficient in regenerate the pulp or act as a scaffold. So the study was carried by Dr. Geraldine and her team in 2018. It was used in endodontically treated teeth. Okay, and they found that, you can see here, the lesion present in the bone, the big lesion in red present in the bone. They inject this lesion with only a PRF, and you can see now the lesion regression and the bone development in such lesion. Also, this study in 2018 by Muhammad Nagih in Fayoum University and his co-researchers, they regain the sensibility of necrotic pulp. You understand what I'm saying? Can you catch me? The sensibility lost in necrotic pulp is regained by the injection of PRF. Okay. As I said, the scaffold could be natural and it could be also artificial scaffold, and one of the materials present for injection of artificial scaffold is a Pura matrix available in the market and is very efficient. The Emdogain, the hero in periodontal department, it was used in periodontic treatments and in treatment of peri-implants healing, and now these are enamel matrix protein. So it could be used as a pulp capping agent, as a scaffold for our treatment. As stated in this article 2022, it has great potentiality to promote the undifferentiated mesenchymal cells present in the pulp to dentine. We need some growth factor for nutrition of these cells. So we have different growth factors in the pulp tissue, and each growth factor is necessary for differentiation of certain function. So, what comes in your mind? I need to form the TBR approach now. I need to form the combination. So, what if we mix the scaffold with the MTA or biodentine, for example? Right? It could be done. I look in the internet to find that I have only 4 studies, that is not enough to be strong evidence, study in 2023 that mixed the PRF with MTA and placed it in a syringe and injected in a cystic lesion, okay? And it's stated, it was a case report, a single patient. It's not strong evidence, but the case is very promising and the healing of this cystic lesion was observed. And I found another studies mixing the PRF with the MTA for pulp exposure, and it was stated also that is where was very successful. So this is about the MTA with PRF. What about the biodentine with PRF? Okay, I found only 4 studies. Most of them are case report, and most of them was on were on endodontic treatments and not on pulp exposure. So I have not the answer. Could we use this mixture to regenerate our pulp and to cap our pulp? Yes or no? I don't have any evidence. So I asked one of my candidates at the PhD, could you carry this challenge and carry this trial with me? Can you? She said, it's okay, let's try it. She's afraid from inside. And I asked Dr. Umayma Safwat, the main supervisor on this research, do you accept something like this? It's crazy a little bit, but do you accept this challenge? She motivates us, let's try, why not? Why not? So I will now show you how we could perform this approach. I will combine the PRF with the MTA. What was the result? It was amazing result, and the research was published internationally in the top 10 Q1 journal. You can scan the QR code for the detail of the research, if you want. Okay, this study was carried on what? 108 patient participants, divided into 2 groups, 54 per group. We are going to use MTA alone as regular treatment, and the other group we are going to use the MTA mixed with the PRF. And let's enjoy together how we are going to prepare the PRF. First, we are going to aspire some blood from the patients. And then we are going, this is my candidate, Rahma. She is lecturer at Bani Suef University, Operative Department. We place the blood in the centrifuge, and the centrifuge will centrifugate at 1,000 RPM to separate the phases of the blood. We will obtain 3 phases. You can see now the 3 phases. The cells precipitated at the base, and a clear solution, the PRP, and in the middle, you can find the gelatinous material. This is the PRF, which I'm trying to catch it with a tweezer. And then we separate it from the solution, place it on a clean glass slab, sterile glass slab, and remove all liquid by a piece of gauze and squeezing with another glass slab. Now we have this PRF. We take a small piece, 1 millimeter. I just want to cap the hole. Just 1 millimeter piece of this PRF. And you can see. And I will place it over the exposure site here with the explorer. And then you can see here, the scaffold is now placed, adapted with a ball burnisher. And then I'm going to place the MTA material. The MTA material, the powder, will be placed and mixed with distilled water, as we know, in the ratio of 1-to-1 ratio. And we obtain the slurry mix. Now we will carry the mix with a carrier and place it directly over the what? The PRF. And then adapted with a ball burnisher. And now we have a mixture of PRF with a MTA on top. And now we are going to restore temporarily our treatment, placing our temporary restoration. And then, for control group, we just place the MTA only. Okay. Now we have, after 5 to 7 days or 3 to 7 days, to re-access, to remove these temporary filling and see what is we have now. This is the dangerous period. Remember the 15 days for regeneration? Now we are going to remove the temporary filling and place the Vitrobond, resin modified glass ionomer, or this is glass ionomer. Okay, just a minute. Okay, and then restore it as usual with the bonding agents, and then composite restoration. And this is the final restoration obtained. And now the outcome of these studies was amazing. We have no failure case in both groups, no failure case. And we could notice that after 12 months there, the mixture of PRF have 93% with MTA, mixture of both material. However, the MTA alone was 93%. What about dentine bridge formation? We need to confirm, okay? So I have a CBCT for the cases, and we could notice the thick. Can you see the thick dentine bridge formed in just 1 year? It's very thick, it's very safe, yes. And statistically speaking, you could see that the dentine bridge formation with the blue and no dentine bridge formation with the blue and yes dentine bridge formation with the red. The success of the PRF for dentine bridge formation opposite to the MTA alone. Okay, so it's very successful and very promising approach. And thus we are going to end this story, this true story, with the molar of the story that we have to save our tooth. This is your mission. Yeah, if you have any question, please.
شكرا دكتور شيرين. It's a very important and interesting lecture. Okay, any question?
هو ده اصلا بدور عليه.